Good afternoon from the annual meeting in San Diego. We're pleased to be here with Dr. Blake Williamson. Thanks a lot, Blake, for being with us today.
So happy to be here. Thank you.
Blake, I know you have a great session at this conference about MIGS, and this is microinvasive glaucoma surgery. It's become so popular and such a great adjunct to intraocular cataract surgery for both comprehensive ophthalmologists as well as glaucoma specialists. I understand you have a great presentation at this conference about the iStent Inject. Tell us a little bit about that technology and how it works.
Yeah, absolutely. We have a great symposium happening this afternoon with Liz Yu, John Burdall, myself, and Dick Lindstrom talking all of our experiences with this device. And many people have heard of iStent. It's kind of like the Kleenex of MIGS, right? They understand the brand name iStent, and it's been a fabulous device, and I've been using that for years. But now we have the opportunity to have two stents instead of one, which just intuitively makes sense. We think that two stents is better than one. So this device comes preloaded on a 23 gauge trocar with two different stents, and it gives us the opportunity to target two different areas of Schlemm's canal.
Well, that's great, Blake. Let's go to video, and then we can describe exactly what it is that we're talking about. Can we start the video, please?
Yeah, sure.
We're going to get a look at how the iStent Inject the procedure is performed. Why don't you guide us through this, Blake?
Yeah, sure. So the first thing you see is we have a nice gonioscopic view of our angle. And I was just showing you the pigmented TM there. Now I'm actually going in with the first stent. I'm putting the trocar into the canal, pushing up against the back wall of the canal, and I've just deployed the first stent there, as you see. And now what I'm doing is I'm just checking to make sure it's seated. You can do that quite easily just by tapping on it with the injector that you already have in the eye anyway, which is nice. You don't necessarily have to come out of the eye. And I'm pushing to make sure I like where it is. Now I'll move a couple clock hours over, and you see that little shiny thing there. That's the second stent. Now I'm dimpling down and sort of pressing into the canal there, and I've just released the second stent. I'm making sure it's seated properly with the edge of the injector. And what you're already seeing there is some heme, and that's actually a good sign. We cataract refractive surgeons sometimes are allergic to blood, but actually a little bit of blood like you see there is a good thing because it tells you there's good communication between the distal outflow system and the anterior chamber. So what I'm doing now is just going in with a little bit of viscoelastic cannula. I'm nudging it again to make sure we're in the exact right position. And it looks like we're doing quite well.
So Blake, I want to come off the video now, and Blake, I want to really press you on the fact that this seems like a very straightforward process. It's a little bit different than the prior generation iStent. Can you talk us through how the newer iStent Inject differs from the previous generation?
Absolutely. I mean, I think that it's well understood that the first generation, while an excellent device, did have a learning curve to it. And while this does have a learning curve, I would say it's a much shorter learning curve. Even after a few cases, this is something that people can get used to. In my opinion, it's a little bit more intuitive. It's a sort of just a point and shoot model versus sort of that swinging or flexion of the wrist. And I think that folks who are looking to adopt MIGS or get started, I think this is a fantastic device for them to get started with. And certainly surgeons who have already spent some time in the angle, this will be something that's very natural and for them to adopt.
I think, Blake, one of the most notable things about the video is that both devices, both iStent devices, are loaded into the same injection system, such that you're not required to withdraw the injector from the eye and introduce, get a new one from your scrub nurse and introduce a new injector. It's all right there in the same injection system, so you have two loaded in that cartridge, right?
Yeah, and you want to spend as little time inside the eye as you possibly can. So by doing that, it helps with efficiency. And I got to say, the two stents also the efficacy is fantastic as well. I actually submitted an abstract recently. We're going to present those data today in the iWorld Theater. My first 50 or so iStent Injects, we have them out to 3 months so far, and had a nearly 30% IOP reduction and a good reduction in medication burden as well. So we're sharing that data. So efficacious, efficient, short learning curve, and really a fantastic addition to our MIGS armamentarium.
Well, I wanted to also ask you about positioning, because it seems like if you're injecting two iStents and you're working out of a temporal incision. It seemed like in your video, one is probably supranasal, one is infranasal. Do you think that that's usually the place where you're going to put them if you're going to do two? And subsequently, if you're going to do just one for whatever reason, where do you pick the location for that one?
It's a great question. So I think that early on in the iStent process, generation 1 years ago, some people had different levels of efficacy than others, but that's because at that time we weren't targeting as we are now as well, at least. So now we kind of know to be looking for darker areas of pigmented TM or little areas of heme in a more lightly pigmented TM, because those are places where collector channels exist, right? And if you get on one of those superhighways, that's when you get those dramatic drops in pressures, which are possible. Sometimes you hit a grand slam. So you always want to target for those if you can. In terms of where to target the two stents, generally it's at 2 and 4 or 8 and 10, depending on which eye you're doing. And you want to do your best to spread them out a little bit, because obviously you'll have access to more of the nasal distal outflow system. Body positioning is a part of that. You want to kind of maybe bias yourself a little bit to the left, and it kind of makes that backhand angle a little bit easier. And these are all things that the surgical rep from Glaukos can help you with whenever you're getting started with the Inject.
Right on. I want to transition as we close to a photograph. Do we have a photograph that we can view, please, regarding the previous procedure? And tell us, Blake.
So, to be honest with you, this is what I really love about the iStent Inject. Microinvasive glaucoma surgery is the term, but really a lot of people think about minimally invasive glaucoma surgery too, right? And when MIGS first came out, in my mind, MIGS simply meant not a trab or tube. But these days, with all these different devices in the market, MIGS really means being as minimally invasive as possible. If you look at this eye, this slit lamp photo, it doesn't look like this patient had surgery. It certainly doesn't look like they had surgery not even 24 hours prior. So this patient actually had femtosecond laser-assisted cataract surgery with astigmatic incisions in the cornea, an IOL placed, obviously, and 2 iStents. So if you think about that, 3 different areas of the eye was operated on, 3 different pieces of hardware, one IOL and 2 implants, yet the eye looks untouched even the next day. So really a fantastic marriage between refractive and refractive outcomes and minimally invasive glaucoma surgery, because the two are coming closer together, and they're more married than ever.
Well, Blake, this has been really such a terrific discussion for us about the utility of the iStent Inject and how you're able to achieve such great post-operative results. Thank you so much for sharing your video, and thank you for sharing your expertise with us today. It's been wonderful.
Thanks for having me.
And thanks to our live audience, of course, supporting us as well. Good afternoon.